management. That is brand new as of last year, 8th edition NRP. Switched it up. It used to be knowing if there's multiples or not, if it's a singleton or twins or triplets or whatnot. That one's now part of risk factors, and they switched it to umbilical cord management a couple years ago because that's how much of a big deal it is for the whole like delayed cord clamping. Remember we were talking about that? Everyone delays the cord pulsating after delivery for about a minute, sometimes 2, sometimes patients' preferences could be 5. I mean, you never know. So asking that question, especially if you have home deliveries going on, they have really strong opinions about how long they want the umbilical cord to pulsate. It's totally fine. Yes?
I know there are like some people out there who like don't want the cord cut.
Mm-hmm.
How do you actually have to go? Like, aren't there some people who like want to keep the placenta attached as long as possible?
Yeah, so rare situation, but there are things called a lotus birth, and I don't get into it because I rarely see it, but it is out there. So, and yes, if you have somebody delivering at home, even with like a lay midwife by themselves, I mean, you can get into some crazy things. I shouldn't call it crazy, but it's interesting that a lotus birth is the baby will be attached to its source of life until the umbilical cord falls off, and then its placenta can go with it. Like it needs to stay a whole being itself. But how long does an umbilical cord take to fall off?
Like 2 weeks.
Like a week or 2, right? So it's pretty crazy that but they will, I think they'll like sage it, put rosemary on it, and they will do some preservation things to it. I don't know the whole process of it, but they may want to, to keep it attached at all times.
But it's not really doing anything before.
Absolutely not. When it stops pulsating, it is not doing anything. One thing that I would recommend is education, right? Especially if the placenta is now delivering. We don't want backflow from your baby getting back into the placenta. And so you don't want to have your baby lose any blood in that way. And so they say that it's pretty minimal when once the placenta separates, that could happen. But it might be some good education to say like, hey, can I, like just wrap a string or put a clamp, like we'll keep it all attached, but can I put one clamp here in the middle just to make sure that your baby's not losing any blood, and we can, do the assessment. The clamp can be cut off at any point. So once we get to the hospital and they're in the hands of the hospital, we can cut that clamp back off. So, I mean, you can do the best you can, keep an eye on it, and all you can do is document that you have educated them to that, right? We're huge in the hospital, documentation, documenting defensively. Ask the patients, recommend it to the patient to do this. Patient denies, education done, patient still wants to do this, will comply with patient's wishes. There's nothing you can really do, so but just documenting defensively.
Is it a cultural thing, the lotus birth?
It's not a cultural thing necessarily. I haven't seen it specifically with a certain like culture or race or whatnot. No, I think it's kind of just a new thing. I think kind of a new trend. Yeah. I know.
Well, yeah,
My sister
I
who was
heard.
she had it made into little pillows and she just
Yeah, but it's specifically called a lotus birth, if you can remember that. And probably because the placenta kind of looks like a lotus flower. I don't know. That's my best guess. I don't really know why it's called a lotus birth.
So just to clarify, sorry, the cord management is like delayed cord cutting?
Yes.
How many like cords to expect, or is that part of risk factor? Like with twins or?
Oh yeah, no, that's part of risk factors now, the whole multiples thing. I would hope you guys have newer books now, so I think that hopefully that is updated in there. But yeah, your 4 pre-birth questions are gestation, fluid, risk factors, and umbilical cord management. And hopefully you asking about their risk factors, they're going to tell you about the twins part, yes. So that's why it was decided to bring up the question about delayed cord clamping with all patients. So yeah, some of them like look at you and they're like, I don't care, I don't know, So do the national standard of about a minute. So, and then arrival of the baby. So delivering, using, blankets. We are wiping down the kiddo regardless if they're crying or not. Honestly, you want to dry that kiddo off. You don't want to have the baby get too cold, which could lead to low blood sugar and shivering, which babies don't have that ability. We'll talk more about that. And then obviously confirming your ABCs if you need to initiate NRP or whatnot. We'll talk more about that. If all's well, you're going to place newborn on mom's chest, suction, mouth first, then nose. It's a big one for sure. Another way you can remember that, people always say like 1 and 2, right? 1 hole to 2 holes, so 1 first to second, yeah. And then keeping newborn at level of mother. So the rationale behind that, that's a good thing to remember, especially by the book. You rarely see that in the hospital. Babies are always being brought up onto mom's chest, so they are a little bit higher than mom, but they're pretty close. But just trying to, maintain that equilibrium of like, babies not getting too much or too less according to the blood flow coming straight out towards that baby. So that's just a baby getting too much or too little of that blood flow during that delayed cord clamping. Clamping and clamping the umbilical cord, there should be 2 clamps in your kit, right? So just think about, you wanna clamp off one towards baby. I would leave a good distance because we do have a lot of hospitals have their own security clamps. A lot of the security devices are on those clamps. That's at, pretty sure Mercy still does that, Chandler does that obviously. And so that way we can attach ours, and leaving a good amount is great too, just in case, especially if you're delivering a pretermer, if a venous catheter needs to be placed for coding, or laid at the hospital for any reason at all, if we're not able to get IV access, leaving that extra length is great too. So baby's out, right? Clamp cut after a minute or 2, your primary survey going on at the same time as treating and doing interventions. So you're starting your NRP, warm, dry, stimulating. And again, head to toe assessment while you're doing that, right? You can do all of it at the same time. You're just kind of like starting at the top, drawing off that head. You're looking for, massive bruising, weird shapes to the head. Is it off to the side? Sometimes babies come out, their cone heads are usually here, but sometimes they've come out asynclitic, it's called, so they're off to the side, or they've come out, just kind of making note of that. And work your way down. Is that both eyes open, but mouth opening symmetrically? How does everything look symmetric? Both arms are moving symmetrically, good tone. And you're just working your way down for looking for any abnormalities, irregularities, inspecting the umbilical cord for abnormalities. Every once in a while you can see, if it's like herniating, or if there is irregular shape, or if there's even a tear in the umbilical cord, which can be a source of bleeding for the baby. If it was a quick, rapid, traumatic delivery, or short cord and it got pulled on, we have had to, I don't know if you guys ever heard of like silver nitrate, which is like those little sticks. I don't know if you ever like, yourself ever got to like the nose doctor and you had like a lot of nosebleeds. My daughter had this one time. They had a silver nitrate stick up there, and it kind of just like seals off. It's like the way of being able to like seal off blood vessels when you're like not in the hospital or whatnot. They did this in the office. We've had to do that silver nitrate like right onto the umbilical cord, just kind of like seal off the vessels. But if not, you're gonna need to keep pressure on the umbilical cord, right, so it doesn't bleed. If there was a rip at the cord, so you absolutely want to eyeball that, which obviously you will be, because you're going to want to put a cord clamp on it, and there's not a length at all to it because it got ripped off. You'll see that for sure. Yes.
I had a cord, one of the first that I watched, that was like very deep purple and super tightly bound like a corkscrew. Is that a concerning cord?
And it was deeply what?
Purple.
So it was deeply purple,
Like
and
the
then
color of the placenta.
yeah, and then it what?
It was like tightly bound like corkscrew. Like it was really.
Oh, yeah. So that's just different shapes. So sometimes they're just like they're straight line. Some of them have it's just like curly hair, right? Some of them have like loose curls, tight curls. They all have different shapes to them. They really truly do. Not a big deal, but the deep purple might have been at delivery. What the theory is that there's just like a little blood clot in there. The blood flow stopped, it's clotted off, the blood that was in the umbilical cord is now clotted. So if it's a deep purple, deep blue.
It was like a placenta purple. It didn't look like there was no blood flow.
Okay.
It looked just,
Okay.
It looked healthy.
Oh,
but
okay.
It was almost like maybe like it was breakdancing in there and just twisted it up like 70 times.
Oh, interesting. Okay, because sometimes you can have there might be like this. It almost looks like a hematoma on the umbilical cord, and that's what I thought you were meant. And so if you do see that, there might have just been some trauma to the cord at delivery, and so there just might be like a little hematoma that formed in there. But yeah, no, there's just different shapes and sizes and lengths, and yeah, it looks like like a telephone cord. They're just like really pretty, and you're like, this is so cool. We all just are like, and then we trash it. It's like it's just different for every baby. Yeah. And then continuing your inspection, you flip baby over, especially, or flip baby out to the side, right? And so when you're stimulating your baby, I love letting gravity be your friend, right? Let that fluid can come out at the same time. That way you can even inspect the back while you do that. The big thing we're looking for is, of course, symmetry on the backside too, looking for any defects at the base of the spine. That's a big one. So sometimes if there is spina bifida questions, there might be an opening, so you just want to make sure you protect that area for sure. Anytime there's any exposed internal of anything of the baby, there needs to be like, you know, warm, wet gauze or whatever you have that needs to be placed at the base. We'll get more into it, there's a lot of like GI conditions too, that sometimes the babies are born with, their intestines are born on like the outside of the body. It's another thing that would be very obvious, and you would protect that too till you get to the hospital, which we'll talk more about that. So just really reiterating hypothermia, so really drying off the kiddo, head especially if you don't have hats, utilizing another dry blankets on top of the head once you've dried off the head, getting rid of towels and blankets pretty darn quick. I'd say, you know, give it a good, those first 30 seconds, you know, warm dry stimulating, get rid of it and get another one on board. Don't waste too much time on the same blanket. All babies are cyanotic right after birth, so we kind of talked about that last week. If you've had a clinical, you've seen most of these babies are coming out pretty purple, pretty blue. They pink up pretty quickly, especially vaginal deliveries, right? They've had a good squeeze coming down the birth canal. Those lungs help to get squeezed, and then coming out and being born, that's where another part of that pulmonary resistance can help. Once the baby comes out, the lungs then expand, fluid gets squished out. Sometimes the babies are born looking up. You can even see as the baby's coming out, there's just the head's coming out, and there's just like fluid coming out. It's pretty fun to watch. And so vaginally born babies tend to do a little bit better respiratory wise, because they do have that good squeeze coming out of the birth canal. So that is one bonus you got going on for you delivering vaginally. And so just making sure the first 5 minutes you're making that baby continue to fuss and cry. I would say at least the first 2 or 3 minutes until you see the baby nice and pink, because that can take minutes. And so as long as baby is doing great in the first 5 minutes, then skin to skin on the chest is perfect for continued thermoregulation. Skin to skin contact from mom can do wonders. Regulates baby's temperature, regulates breathing, and so baby might want to start breastfeeding pretty quickly, which can help you with, remember, oxytocin release from the breast for bleeding. Skin to skin does wonders. We have in the hospital and at home, there is what's the big thing nowadays too is called the golden hour, and so they want their babies on their chest for the first hour. We do no interventions, that bonding, the warming of the baby, and just their transition to life has shown by studies that is so much better if you can do the golden hour. And that's obviously if the baby can tolerate that. So APGARs. So we talked about this last week, just scoring your baby on a 0, 1, 2 scale, total of 10. Rare to get a 10 at the 1 minute mark, right? So those babies are working hard to get rid of fluid, oxygenate themselves, get a good respiratory rate going. Most of that does not happen in the first minute, so most APGAR scores of 8 with our normal term babies is very, very normal. And then by 5 minutes, you can get 9, sometimes 10s. And even that's pretty rare actually, because a lot of times we have APGAR cyanosis still going on even by 5 minutes. And that is normal for the first 24 hours of life. So I always tell moms that, cause they'll like grab at their baby's hands, they're like, oh, their hands are still purple. And so I always remind them of that. Like, that's okay for today, the first 24 hours. Everything else should be pink though. That your baby should be nice and pink. And you let us know if your baby is not, right? Because we don't have eyes on them 100% of the time. Any questions on APGAR scoring? Okay. So we have what? Color, pulse, tone, respers, irritability, right? They react to your stimulus. They like irritated by you. I like to think of it that way, or grimacing, like, you know, like just are they reacting to you? NRP, so first 60 seconds, and we're gonna do your initial steps, and ventilation should occur. That is my big soapbox. I'm gonna jump to the actual algorithm, which is teeny tiny. But you guys will see here that there's this red line, and it says 1 minute. There's a lot that happens in the first minute, right? That's like, you know, half of the algorithm that's happening in the first minute of life. So that's why I really stress rapid evaluation. Birth is here. These are your pre-birth questions, right? Birth, and then it's after birth. These are the 3 questions you are now gonna ask yourself after birth. This is a test question. So you have pre-birth questions, and then after birth. So is that baby look term? Does it have good tone? And is it breathing and or crying? Crying is so much better, right? Because you can hear it, you don't have to look for it and whatnot. But sometimes you don't have good criers, and so they just, you know, look at their abdomen, see if their belly's moving up and down, or their chest rise, right? And so term, tone, and crying. So yes, we're gonna pop over here. This is just stating that if it gets stated with mom for routine care, the golden hour, vital signs, continuous observation, right? So this is gonna be 85% of our deliveries it's gonna cut off right here. If baby, you know, is even just one of these is a no, right? So we have term baby, it's having good tone, but it's just like looking at you like, you know, wide-eyed, and they're just like this happens a lot where they're just like, what do I do now? Like, you know, you need to stimulate them. Warm, dry, stimulate, and suction if needed is this box. And so if baby's not doing everything baby needs to do, you're gonna warm, dry, and stimulate, and that's another 10% of our babies, right? So we're up to 95% of our deliveries, and so that's all you gotta do. We do with 100% of our babies, regardless if they're screaming or crying, right? Because we want to dry off our kiddos so they don't get cold. If baby is still apneic, even though you're like rubbing on baby, you're, you know, rubbing on his back, rubbing on his feet, you're trying to get this baby to start crying, maybe still has good tone, you're listening to the heart rate, you're gonna set of vital signs immediately. If you do not hear crying, your stethoscope better be on your baby's getting an apical pulse, because you need to now figure out what baby's heart rate is, right? So it says apneic or gasping. These babies breathe fast, right? 40 to 60 breaths a minute is norm, are their norm. And so these occasional little cries or gasps or whatnot is not good enough to ventilate themselves. And so if they're apneic or gasping, or the heart rate is below 100, you're gonna be doing PPV, applying all monitors and starting PPV, and this is all within 1 minute. Because again, you have, that is a really long time to be not ventilating yourself, not getting good oxygen. But part of that, which the delayed cord clamping we have talked about, can help with some of this, right? So you're gonna be getting some gas exchange, hopefully, from mom, and so doing all of that warm, dry, stimulating while still attached to the cord is hopefully gonna set baby up for success to getting a little bit more of that gas exchange at the time. And so if that's not happening, I would cut the clamp here, and let's get baby over to, you know, away from mom, or maybe just right next to mom, so you guys can get started on doing some PPV. So we want to know what's going on with PPV. I don't mean to block you, because we need to know how well our ventilating is doing. You see the little box that's the targeted SpO2. That's a big one to remember also. It's gonna help you to stay calm and remind you that you're doing a good job. Babies, SpO2 is low, and so they start off at 65% at 1 minute. So if you put that SpO2 on baby on their right hand, always their right, and you get a SpO2 reading of like 65, 75%, that is okay. Yes?
I can't remember the term for it. Can you elaborate on the right hand only?
It's just the pre-ductal, what's happening, like coming into the lungs and whatnot. So we want to know what baby's current oxygenation status in the blood is. So that's why you always do it on the right hand or right wrist. Sometimes if you have a super purple, blue hand, please move it up to the wrist if you're not getting a reading and whatnot. Again, you have purple hands, there's not good circulation happening, you're not gonna get a good reading. I actually, sometimes if I automatically see super purple hands, which you're pretty much going to, I automatically just go straight to the wrist. Instead of like doing the whole like waiting, it's not registering, and then moving it up to the wrist. So a little bit better. Yes.
On that too, like, so, I asked the same question at one of the clinicals. They said something about like a hole in the heart temporarily until it closes too. Is that something?
Yes,
That's
I mean, sure, yeah, so during the first couple of minutes of life, you have all the, different shunts are closing up, the holes are closing up, so good, oxygenation is not quite happening. And so that's, so our SpO2 readings are gonna be low as the lungs are, getting oxygen to the body, and so starting out low is okay. We give these babies up to 10 minutes to get into the 90s. And so if you can remember, every minute it's gonna increase about 5-ish% each minute. As long as you see an increase as you're ventilating your baby, that is okay, and you're doing a good job. You see chest rise, you see your heart rate increase as you're doing PPV. You should just be having somebody listening to the baby's heart rate at all times during PPV, one person listening for that. It's above 100, then continue with your PPV. And you see the SpO2 rising, you're doing a good job. And so that is gonna be, most of the time, the only thing you need to do is to jumpstart your kiddos and doing 30 seconds of PPV. You're gonna listen for that heart rate again, because the number one way we know we're doing good PPV is an increase in the baby's heart rate. So that is a test question also, you're gonna see that. If your baby's heart rate started out, at 80 and you're doing PPV for 30 seconds and you hear now that it's at 120, you're doing a good job. Keep doing that. Yes, you're gonna be looking for physical signs, you're gonna look for chest rise, you're gonna be looking for the SpO2, those are all physical symptoms, but NRP states the number one way babies are getting good PPV is the increase in heart rate. So we have PPV happening. You do this for 30 seconds, get a heart rate. The heart rate is above 100, but baby's still not breathing on its own. You're gonna continue that, and that means the baby is perfusing itself fine. Its heart is working just fine. It's just not breathing. They are respiratory driven, right? So those babies are just not breathing on their own. So you're gonna just be ventilating then at a rate of breathe 2, 3, breathe 2, 3, breathe 2, 3, right? So that's gonna be a little bit slower than if you were doing chest compressions with that. And so remember, you're trying to get around 40 breaths per minute, right? So doing the breathe 2, 3, breathe 2, 3 is gonna get you there. And then you're gonna do that for about a minute, just like in CPR. We do everything by the minute. And then if you assess the heart rate again, it is below 100. Oh, let's bounce over here. So I apologize. So if you have a baby that has a labored breathing, persistent cyanosis, these babies are breathing on their own. Let's say you don't have to do PPV, they have a decent heart rate. Let's say the heart rate's 130, baby is like, respirators are 30, they have persistent cyanosis, or they're just labored breathing, they just might need some blow-by, right? They still have central cyanosis at 5 minutes of age, 7 minutes of age. They're not pinking up as they normally should. Then you definitely attach them to the monitors to watch your values to see if they're going to increase on their own. And if not, I know that most of you guys can't do CPAP on kiddos. You don't have the ability to do that. So you're just going to be doing, blow-by all the way to the hospital. Set your babies up for the best success that you can. There's not a lot you can do. If you work for a high-risk transport unit that you can do some CPAP, you might just have to maintain some CPAP just to help keep those lungs open, right? There might be meconium in those lungs, there might be thick mucus, blood. There's something that is not allowing those lungs to stay open, ventilate, their bodies, well, maintaining an SpO2 well. So, CPAP is, your next, box down. If you have a baby that, sure, has vital signs, you don't have to ventilate for them, but why are they not pinking up, right? All babies should pink up, so there should be a change, from that 1 minute to 5 minutes. And sure, you wanna give them a few minutes, you don't need to, freak out and, jump to ventilating as long as, you see that they are slowly pinking up. But why are they not, why are they staying persistently, cyanotic? And so that's where this is just kind of like those borderline, babies kind of reaches, down to this. For you guys, there's not a lot you can do, but doing that, blow by. And also, maintaining a good, position for those kiddos to be able to optimally breathe, right? You're gonna keep babies, like chin up, open the mouth, looking for fluid coming up. Maybe they just have extra fluid in there that they're, like when we get to the hospital, we're gonna be doing some deep suctioning, doing our DeLee suctioning, if you guys saw that all or heard of that. We might need to help clear out their lungs. Their bodies aren't able to absorb their lungs for some reason. Maybe they're premature and not able to do, everything that they need to do to help themselves transition. And so, that's something that you might have to do, for them, is just give them that good breathing position. Just open mouth, look to see if you need a suction for them, and keep their chin up. So back to you at 1 minute. You're doing PPV, putting all your monitors on, because anytime you're doing anything kind of more than the norm, automatically, that was another change, is you're automatically, last year, the monitors need to go on immediately. You need to know if what you're doing is improving the respiratory status of your baby. If not, let's say the heart rate is still below 100 or baby's not breathing on their own, this is where Mr. SOPA comes in, because a lot of times it's human error, right? So you don't see a good rise, you don't see that the baby's heart rate is not coming up. So why not? It could be us, right? And so you have mask adjustment, and then reposition. And these two, and it's called Mr. SOPA on purpose, because they the first two things need to be done first. If you can go so you can see it. Okay, maybe I won't jump ahead quite yet. That way you guys can follow this a little bit closer. Okay, so let's get over here. Got all that. So this is just a picture of the blow-by we were just talking about. You can see the chin is up. If you need to fold up a blanket into thirds or quarters and place it underneath the shoulder blades, that can really do the job for you to help keep, because these babies have large heads, right? So the illustration is kind of really showing that for you. A lot of times they have a lot of captive, just swelling, molding in the back of their head. So they, you place them down and they're automatically gonna do this, right? Because their head is all swollen. So putting a towel behind their shoulder blades can really help with that positioning. Airway management. So there is a lot of fetal conditions that can affect your ability to give oxygen to your newborns, right? So these are really, really rare, but possibility of them happening. So a lot of these you might need to put in like an oral airway. So bilateral choanal atresia. So this is just like the narrowing of the airway that's happening. The Pierre-Robin sequence or condition, that's this picture I'm going to just jump over to really quick to show you. That is where just like really underdeveloped jaw, and sometimes this can be really difficult to intubate or get an airway in. So it's just a smaller recessed mandible. The jaw is just is really difficult to get that kind of in a position to intubate. And then, the macroglossia, that is just a really large tongue. And so that can be, something that can be hard for intubating with like LMAs and whatnot. You might have to use, an ET tube, down the nostril for a lot of these. Like it says the atresia, where we have narrowing of the airways through the nose and through the throat. Those can all be really difficult. Craniofacial defects, these are just, a lot of babies that have like cleft palates, just like inside of the mouth where the palates have not fused together and they're open inside and everything's kind of exposed. Obviously there are gonna be some reasons that it's gonna make it difficult for doing intubation. So just some of the obstacles that can be in the way. And then again, just using the nasal airway if you have any of these types of conditions. Bag mask ventilation. We can jump back into our NRP. As you can see, baby's not breathing, apnea, inadequate respiratory drive, less than 100, right? So here's a good picture of getting a good seal on your kiddo. So you're gonna, the top and the bottom of that mask, you're gonna make sure the mouth and nose is included, and you're gonna try to get a good seal. You see them have a towel underneath the whole body, not really necessarily just under the shoulder blades, but just something that's gonna elevate the body away from the head. So that's really just to kind of, they did a good job at showing that. So these are just different ways of delivering ventilation. I think most of you guys have what's in the picture. So we're trying to ventilation rate, right? 40 to 60. Remember that? That one is definitely gonna be a test question, just knowing how often to deliver respirators. Causes of ineffective bag mask ventilation, right? So not a good seal, which is where Mr. Soka is gonna come in. Incorrect head position, so positioning the body on something that's raised. Lots of secretions, equipment malfunction, which is gonna be where we talk about Mr. Soba, and then a pneumothorax, right? So we've lost the ability for that lung to be inflated because of a pneumothorax. Indications for intubation, prolonged PPV, so our PPV is not working, that's pretty far down the NRP algorithm. We will get to that. That is, obviously if PPV is not working, we might need to intubate a baby. Congenital diaphragmatic hernia, so that is where the diaphragm, we have a herniation that's coming through the diaphragm, right? It's coming up through, and so it's gonna prevent the lung expansion. So that's another really rare condition that can cause ventilation to be difficult and not allow those lungs to expand. So that's something that you might not hear. Let's say you bagging the baby, you get to intubating the baby, you're listening for breath sounds, you might only hear it on one side versus another with the diaphragmatic hernia. Craniofacial anomalies impeding the airway, like the conditions we just talked about. That can prevent, that might need you to intubate and going straight to that rather than doing anything else. And then meconium, as we've said a million times, meconium can be really dangerous. So it can coat the baby's lungs and not allow the lungs to open up. Those air sacs just will not be able to maintain. Equipment needed. So this is just everything to intubate. I know you guys know your suction equipment, laryngoscope, blades, a shoulder roll, tape, ET tube, stylet. Sometimes if you're doing PPV for a long period of time, you might need to put do you guys have feeding tubes in your kids just to help with buildup of air as you're intubating? Okay, perfect, yes.
Before we get too far,
Yeah.
the hernia on the last one.
Yes.
Are they gonna know before the baby's born that they have it or not?
Yeah, so again, if you have a patient that has prenatal care, hopefully that is something that is gonna be in the pre-birth questions, risk factors, the patient should know. They will see that on ultrasound. Ultrasounds nowadays are great, they're detailed, they're high level. And so, that should be something that the patient will know, yes, absolutely. But again, there's women that, only go like once or twice or not at all, and so that's a possibility of just not knowing that that's, a possibility. Yes?
And then just to add on, I guess, to that, if, it says they're suspected clinically the newborn has decreased breath sounds on the left side. 80 to 90% of diaphragmatic hernias are on the left. Does
Oh,
that
okay.
sound true to you?
Say that again? Is that?
That 80 or 90% of the diaphragmatic hernias are on the left, and it's suspected clinically, I guess in the film, the newborn has decreased breath sounds on the left side.
On the left.
Does that sound like something that you heard, or?
Yeah, no, I mean, so that's good to know. I didn't know that it's more on the left side than the right, but yeah, that's awesome to add to it. So yeah, there's definitely decreased breath sounds on one side over the other, because the hernia will go up, naturally up towards one side or another. And so, that's cool, that's good to know, yeah. If you guys can remember that, that's great. But if you're listening for, equal, breath sounds on each side, and you notice that there's one over the other is not there, that, it could mean pneumothorax, right, or it could mean a diaphragmatic hernia, yeah. Gastric decompression, if that's something in your guys' scope, then that's something that you just place down the baby's throat, just to kind of get some release of the air that's going into the stomach. Because again, if you have the belly filling up with air, then we're gonna have a difficulty with ventilating these babies also too, right? Because it's gonna have increased distension, abdominal distension, and that's just gonna impede your ventilation. So if you're ventilating longer than several minutes, then I would consider placing that, because that's gonna possibly, if you feel like you've been ventilating decent and you're feeling some resistance or whatnot, that distended belly could be contributing to that. Chest compressions, so if you have a, let's see here. Since we're jumping to chest compressions, let's just do this. So mask readjustment and then reposition the baby. That is, again, just making sure the body is rose. If you're trying to ventilate and the baby's, chin is down and whatnot, getting that head repositioned and the mask adjusted. Did you have a good seal? Was it, do you need to, open the mouth a little bit and adjust the mask? And whatnot, is if there's any facial defects in the nose and you're trying to ventilate the baby with the mouth closed, opening up the mouth and having an opening towards the mouth and the nose. These two things fix most of our human air ventilating causes, honestly. Do you need to suction this kiddo because there's blood, there's a big mucus plug that's in the throat? This can help if ventilation's not going well, heart rate's not rising, central cyanosis is continuing, that sort of thing. Open the mouth. Again, look inside and see if there's anything that's in there. Pressure, do you need to increase the pressure? I know you guys don't do a lot with pressure, changing pressure when you are ventilating. But again, sometimes we just need to increase the PIP and increase the pressure to see if that might help just open up the lungs. And then if none of that is working, then of course the most invasive is always at the bottom, considering an alternate airway. If PPV is not working for you, then we're gonna go to intubation. So that is Mr. SOPA. You definitely know what Mr. SOPA is. I'll give you guys a break shortly, I promise. And then chest compressions. So we have a heart rate that continues to drop. You're ventilating the baby. You know that babies are respiratory driven. PPV is going to almost always get your heart rate back up, open up the lungs, get that baby crying or reacting to transitioning from intra to extrauterine life. You have done Mr. SOPA, you have warm, dry, and stimulated. This baby's heart rate continues to decline, right? you feel like you've done everything right, this is all happening within, minutes, and you have a heart rate that is now below 60, you are gonna start, chest compressions. And so, this is, 2 people, obviously, that are gonna be, doing this together, and so you are going to, let's just go to the next one. You're gonna have 2 techniques of doing this. The ideal and the one that is always recommended is gonna be the thumb technique. So it's just easier to not like slip. The 2 finger is just kind of harder, to, for slipping or whatnot. It can be hard. There's a lot of people that are doing stuff, but trying to get everyone's hands in there or whatnot. So I know some people want to just like reach in and start doing compressions because it's just one extra arm that's in there. But again, this one is done. It's usually most effective. How deep do you compress the baby? I don't know if anybody read ahead. How,
1/3.
Good job. Yeah. So one third. So pushing down pretty deep to get that heart to be compressed is best. 1/3. Not delivering simultaneously, right? So this is going to be very coordinated. So instead of doing, if you're just doing PPV and you're just doing Respers, it's going to be breathe 2, 3, and repeat, right? When you're doing your coordinated, you're going to do 1 and 2 and 3, breathe. So you're just gonna pick up the pace because we need to get these all of these sequences in pretty quickly. You need to get 120 events happening right within 1 minute. So these are like half seconds each, right? So you're doing like 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. So pretty quickly, you guys know that baby's heart rates, they are pretty fast. So all this is quick. And then you're gonna do light, gentle squeezing, which we will practice that a little bit today too. And you're gonna repeat that for 1 minute before you go to reevaluate. So coordinated is keyword here. Because they'll definitely get that on a test question. 120 events per minute is another key thing to write down. You gotta get a lot of events in that short period of time. Events, they just call them events, yeah. Okay, so you had a heart rate less than 60, started chest compressions and ventilating, you're doing 120. Within that minute, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. 60 seconds have gone by of well-coordinated compressions and ventilations. You're gonna do a pulse check. If it's above 100, great. You're gonna slowly, you're not gonna automatically stop. You're just gonna slow everything down, decrease how often you're giving everything. Did they tell you exactly what that means? No, but you want to give the baby a chance to kind of take over and start breathing on its own and whatnot. So, for like in the hospital, we would decrease our pressure if we had increased our pressure or whatnot. If you're, I think you guys only give 100% oxygen whenever you do ventilate. If you work for a high-risk transporter in the hospital, we start out at room air. We don't give oxygen. We start out like 21%, sometimes 30%. But if we get into doing compressions, it does get cranked up to 100%. We want to have the baby have the best amount of oxygen and set up for success the best with 100%. But that is on NRP. They'll talk about where preemies. They'll start off at 30%, and term babies will start off at 21%. We don't want to unnecessarily give oxygen to babies and have them be exposed to pure oxygen just because of tissue damage and whatnot. And so sometimes, like again, just ventilating those babies, physically opening up their lungs, physically opening up those air sacs can jumpstart a good respiratory pattern and breathing on their own. Yes.
Sorry, terrible question. With neonates, are you doing the same chest cracking with the compressions, like first compressions, are you gonna get the ribs popping or not?
Yeah, that's a good question. Yeah, no, you won't, because babies are very soft. They're flexible and soft and whatnot, so you won't. Yeah, that's it's a valid question. Yeah.
This is liver laceration you're calling.
So that's why being really good about like constructive criticism with each other, you know what I mean? Go faster, you're not, this is, you're not ventilating fast enough. These babies need a lot and fast. And so that's something that you can't have your feelings be hurt and be able to give good constructive criticism with these kiddos. Is we see it all the time whenever we're coding a baby or having to give PPV. Sometimes I even just take the bag from some of my cohorts, be like, oh, I'll do that. So yeah, because they're just not doing a good job. I'm not seeing they've adjusted, they're not giving good PPV, and be like, I'll take over, like, let me, you know what I mean? So yeah, you don't want to just not see something and whatnot, so obviously. Vascular access, if you have that in your scope of practice of giving or policing, I know you guys can't police catheters, venous catheters, but I have had these talks in this class and been backed up by Matt and whatnot about placing it. If under medical direction, you need to place like an IV into it, like again, you're gonna leave that nice long cord, because if you get stuck in a conundrum where you need to give epi and you don't have good IV access, you can go to the umbilical cord, and that can be your saving grace for sure for giving epi. So
yeah, so if you do deliver a baby like that, just make sure that you do leave extra. As far as like umbilical IVs, it's going to be really kind of dependent on where you end up working at and say how you do that. I've never placed umbilical IV. I know there's a handful of places here in Cali that allow it. If you are not able to place an umbilical IV, you do femoral IOs. That's the go-to route as well. So, as far as placing the umbilical IV, it's not like we're actually doing in the hospital. We're actually going into placing that catheter in the stomach area. It's more distant, so it's further away from the body. No, you're just looking for the big thing. Big thing.
So do you guys get to look at any umbilical cords?
Yeah.
And you can see through them, most of them. It's really nice. It's pretty easy-ish, I guess. But you can see there's like the big juicy vein, and then there's two small arteries, and those are actually pretty hard to see because they're pretty small. So if you see the large, that's your vein.
So you
Just
can
place.
use any, like just a regular IV?
Yeah, so-
Yeah.
It's not like a specific.
As far as
No,
like,
oh no.
yeah, IV access and stuff
Yeah.
like that goes, correct me if I'm wrong, but
Yeah.
typically, like an umbilical IV is it's being cut and you're actually placing and it's being sutured in place
Sure.
versus you're just gaining access through there from the outside.
So we secure it.
Yeah, how do we secure
Okay. So probably the same. Yeah. So this is like the cord, and so you're just gonna go in on top here, right? And then I would say, I mean, tape it the best you can, or do what you can, right? You're not gonna have any other option, but yeah, so you'll just go in, leave along at least this much, I would say, before, clamping. I would say that's at least appropriate, and that way you can go in here and then have your access here. And then I would stabilize that because it's gonna move on you, right? So you don't want that catheter that's now in there then to puncture through, and then it's not working for you. So stabilizing this, taping it down, someone holding it, that's all they do is just hold that down, so you can give epi through it. But yeah, it's not ideal. I would say it might be something to try while someone's getting out the IO. I would say your IO is probably best, honestly. But it's something that if you can get a dose of epi in through while the IO is getting out, and they're getting it prepped and they're doing the actual IO, that might be something you can get a dose in. And
Also
go in.
remember, like epinephrine, as you guys learn going through these chapters, like isn't like a high priority. if it's ventilation, CPR, right? Even defibrillation and stuff like that, that's typically like pretty late, you know. You deliver these kids, you'll recognize that it's, you know, bradycardia and hypoxia is what's killing them. So when we talk about like ACLS and PALS and stuff like that, we're looking for the reversible causes. Those are the reversible causes. Right? Very rarely do kids have, you know, heart attacks or dysrhythmias or anything like that. The dysrhythmia is coming from the bradycardia secondary to the hypoxia. Does that make sense?
Yes.
Yeah, and then if you get access through the vein, or IO, this can also, get you access to sometimes when you have trauma, you have, you know, this placental abruption, uterine abruption, baby might have, you know, baby's very pale, you might have to give, some saline through, the IV or the IO. This will also give you access for that too, so if you feel like baby is needing, some volume resuscitation, this will help with that too. So that's really the big fixer of another, if you're not fixing it, respiratory wise, you know, was it a traumatic, was it a car accident, baby's delivering, you know, was there some abruption, so sometimes fluid resuscitation is the reason for it. For help them.
Yeah. So a lot of times you do have a kid that does come out and they are coding, you are doing CPR, you're packing them for prolonged periods of time. You do have to monitor their glucose as well. So as you're working the kid, you're gonna use up a lot of the sugar reserves, you know, and because you are doing CPR and bagging from them, they're unable to nurture from mom, obviously. So you're gonna have to continue monitoring that. So you may have to administer dextrose or sugar.
That was really deep touch.
You do a
Center
infusion
component.
after you administer the 40% dextrose. You do 10%. Would you do a 10% after the infusion after you the initial dextrose?
Yeah, so you're talking initial or?
The initials.
That's the question, yeah.
Yeah.
Let's see here. So we already said this, so obviously, your IO access is gonna be common for you guys, whatever you guys are, have the authority to start and whatnot. But again, this is gonna be, pretty rare, again, respiratory driven. That is a test question. They will really emphasize with you guys, these babies are respiratory driven. They don't have a lot of cardiac anomalies. There are rare cardiac conditions that babies can be born with that is, you know, you're just gonna have to do NRP on them, CPR on them, all the way to the hospital to help maintain a heart rate, because their heart just physically cannot, and then they'll be put on machines and they'll be, you know, be kept alive like that until they have surgery and whatnot, and we'll talk more about that. But again, good ventilation and doing a little bit of compressions is usually gonna fix all of this. So, bonus an NRP, there's only one med and it's epi, so that is nice. It's definitely weight based. I usually just remember it by our mLs per kilo, but there is a whole way to calculate it. You guys probably have it. So, Okay, so this is, to me, the easiest way to remember it, cause you're gonna get a quick assessment on your baby, kinda guesstimating how many kilos your baby is, and so, just knowing when you're gonna pull up, usually we, out of the package, it's gonna allow us to pull up 10, 1cc syringes. And so, we usually have 10, syringes ready to go. Someone's pulling it up while, we are coding the baby if we think we're gonna give it or not. And so, the, ET and the IV doses obviously are a lot higher, intubation wise, because we're not right in the umbilical, umbilical vein and whatnot, so that's gonna be a lot higher. We're gonna be putting it into the mucous membrane, and it's gonna just take a lot more to be absorbed. Yes.
For the dope, is it, 0.01
So in your books, okay, with 8th edition last year, so this might be a little bit newer than your books are, they have simplified it, so you might see this a little bit off from your book, so good question. And so there used to be a range forever. There was, what was it, like 0.01, so 0.03? Yeah, and so they've simplified it as of 8th edition, and so, which was, January of last year, and so this is really, really nice. So now we just only have to remember 1 ml per kilo for, ET dose, or 0.2 ml per kilo. And so, this has really helped with, getting things, going and kind of averaging everything out. What your test is gonna ask for, I don't really know, do you know that, Matt? And so,
I think most of your tests are gonna be based off of what Alice patient.
okay, yeah, I don't know if they're gonna, they'll get into this on your test, but just knowing for NRP, I like to stress that most likely getting an IV or IO access is gonna be pretty unusual, pretty rare. You're gonna be starting off your code, probably intubating, and so you do, give that first dose or two through the ET tube. And so just remembering 1 ml per kilo it's easy, it's simplified, and so that's what you're gonna give. You have like a 2 or 3 kilo baby. Most term babies, I would say they're around 3 kilos, so giving 3 cc's for that first dose or two while you're getting IV or IO access. That's gonna be, trying to simplify it is what they've done, so. Yeah, I didn't realize that it wasn't updated in your guys' stuff, yeah, that's a bummer.
This might be older, it's, the 2020 edition, so
Okay.
I don't know.
Yeah, the 8th edition came out in, I think, 22, like January of 22 for NRP, so that makes sense, so, yeah. So if you guys are good with numbers, you're good at memorizing stuff, if you can remember, 1 ml per kilo, that can really help you if you're involved in, resuscitating of a newborn, if you get to this point.
I have a question.
Yes.
For the numbers on the board, so in the 1 milliliter, is there 0.1 milligrams in the 1 milliliter?
Correct. Yes. Yes.
Are you talking about the concentration of the drug on the top? It's I believe that's our 1 to 10,000.
Correct, yeah.
Okay.
Yeah.
Are you ever worried about liquid flow overload or no?
I mean, sure, yeah.
30 cc doesn't sound, I mean,
But
it
you have
sounds like a lot. but-
no access, I know, to their bloodstream, and so this is what, they're trying to absorb it somehow through the mucous membranes in the lungs, and so, yeah, that's, yep. So, imagine giving, like, you're on 3rd or 4th dose ET tube, because you haven't gotten, access. It's a lot, right? Yeah.
I just feel like that sounds like.
So when you're ventilating, a lot of it is going to be like hopefully pushed, and you're pushing it through into, the body somehow, hopefully, and so, yeah. Yes.
Do you see the ET route commonly used or not really?
Say that again?
Do you see the ET route used commonly or not that often?
So, I mean, in the hospital, no, not at all. Maybe the first dose, max, because we have, we have neonatal doctors there 24/7 at Chandler especially, where we have 24/7 like coverage at all times, and so rarely, maybe the first dose. Yeah. I know. So lucky, that way, so. So obviously you're gonna be stabilizing this kiddo. If you get into a good routine of doing some ventilating and compressions, and like I said, you might not have a baby that ever starts breathing on its own. Maybe there's an unknown cardiac condition. You might have to be doing these, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. And then giving a dose of epi every 3 minutes, and you'll just be doing that all the way into the hospital because this baby's not responding, and it might not make it. There might be a brain injury, that the nervous system is not allowing it to be able to respond to any stimulation at all, and it might not have a respiratory drive, and it might just pass at the hospital. So that might be something to consider too. But as long as you do the best you can and you're doing that all the way in, that's all you guys can do. And then obviously educating the family to what you're doing, as we do with all of our peds patients. And so that's the best you can. Even if you're just doing PPV or you're doing blow-by, just really educating parents that your baby just needs a little bit of extra oxygen. It's premature. It's not maintaining good pink color, so that's why we're giving baby oxygen. I'm sorry, but I'm gonna keep, we're gonna transport you guys separately because we need to be able to watch your baby closely and maintain a good position if we need to start doing any other extra interventions on your kiddo. So just explain to the parents want to do what's best for their babies and whatnot, so that's all you can do, right? Good education. Let's give you guys a little break.